In the two following tracings, we're going to see the functioning of the SecureSense algorithm in case of P-wave oversensing. In this first patient, you can see that there is oversensing on the bipolar channel of the signal preceding the QRS. This signal corresponds to the P-wave, so there is sustained P-wave oversensing on the bipolar channel, but not on the discrimination channel, since there is only one VS2 marker corresponding to the QRS. Here, the VF counter is filled, so there is going to be an interrogation of the noise counter. The noise counter has been incremented by 1 for each of the short cycles on the bipolar channel, and it is not reset to 0 since there is no short cycle on the discrimination channel. Therefore, there is a diagnosis of RV lead noise, and the therapies are inhibited. This is now a second patient, with also a P-wave oversensing at the level of the bipolar channel. The difference here is that there is also oversensing at the level of the discrimination channel. You can see here that there is a VS2 marker corresponding to the P wave and one corresponding to the R wave. On the bipolar channel, you can see the alternance between one unclassified cycle and one cycle classified VF. So there is a progressive increment of the VF counter by 1, 2, 3, 4, 5, 6. Here, the VF counter is filled, so there is an analysis of the noise counter. You can see that there are repetitive short cycles in the discrimination channel. Therefore, the noise counter is constantly reset to 0. At the time of the diagnosis, the noise counter is less than 10, and therefore the therapy will be delivered. A burst during charging is delivered. You can see that after the burst, there is a persistent of the oversensing on the bipolar channel. Here you can see the shock that is delivered with the end, at this time, of the oversensing and the diagnosis of return to sinus rhythm. Oversensing of the atrial signals occurs preferentially in two circumstances: in case of RV lead dislodgement at the AV junction, or when an integrated bipolar lead is implanted near the tricuspid ring, with the distal coil straddling the valve. As demonstrated before, this algorithm can really decrease the amount of inappropriate therapies in case of T-wave oversensing. It seems that it is less efficient in case of P-wave oversensing, particularly if the discrimination channel is set between the coil and the can. Indeed, the coil is near the tricuspid annulus and therefore near the atria, and the chance to record atrial signals is probably more important than with the bipolar channel. Therefore, if there is oversensing also on the discrimination channel, then the device will not recognize oversensing and the therapy will be delivered.